Good evening, everyone. Now I'm going to briefly discuss microvascular complications in patients with type 1 diabetes mellitus. As pediatric endocrinologists, we're all very well aware of acute complications of type 1 diabetes mellitus, which include hypoglycemia and diabetic ketoacidosis. The complications which we are less familiar with are the chronic complications, which include microvascular and macrovascular complications. The microvascular complications include retinopathy, neuropathy, and nephropathy. Each one of these significantly add to the morbidity and mortality in patients with type 1 diabetes mellitus. Retinopathy leads to visual impairment and blindness, whereas the distal peripheral neuropathy predisposes for ulcerations in the foot, often culminating in amputation of the lower limbs. It also leads to other manifestations due to autonomic dysfunction, which include postural hypotension, gastroparesis, diarrhea, bladder dysfunction, and impotence. Each one of these are a significant morbidity in patients with type 1 diabetes mellitus. Not only that, these autonomic dysfunction also add to mortality by increasing the hypoglycemic unawareness, and also a cardiac autonomic neuropathy itself is an independent risk factor for increased mortality in patients with type 1 diabetes. Nephropathy is a straightforward one to understand. It leads to hypertension and renal failure, often requiring renal replacement therapy and or renal transplantation. I think this clearly tells why we should avoid the development of these complications, or why we should diagnose them early and treat these microvascular complications. If we look at the prevalence of microvascular complications in patients with type 1 diabetes mellitus, I pulled out here two relevant studies to match the current scenario. One study is by Cho et al., where the duration of diabetes at the time of assessment was between 2 to 5 years after the diagnosis of diabetes, with a modest A1C control with an A1C of 8.5%. Look at the prevalence. Prevalence of neuropathy was 16%, retinopathy was 6%, and nephropathy was 3%. What does it tell? It tells that at least a smaller proportion of patients with type 1 diabetes mellitus, though their duration of diabetes is less than 5 years, still manifest microvascular complications. Probably it's these kind of data which made ISPAD to modify its guideline to initiate screening of microvascular complication from 5 years after the onset of diabetes to 2 to 5 years after the onset of diabetes. Another important study I would like to quote here is the SUT study with a diabetes duration of 7.9 years with a relatively good control, that is A1C of 7.6%. Still, the neuropathy prevalence was 8.5%. Retinopathy and nephropathy were seen in around 5.6 and 5.8%. Again, what does it suggest? It suggests that at least a significant proportion of type 1 diabetic patients whom we are catering to in the pediatric age group, that is before 18 years of age, will still already are having microvascular complications who should be diagnosed and addressed. Moving on to the pathogenesis and risk factors. I'm not going to take much time on pathogenesis because I'm sure all of you are very familiar with, but just for the sake of completion, I'm just going to mention the 4 pathways which are involved in the pathogenesis of microvascular complications. That is the polyol pathway. Second one is hexosamine pathway. Third one is protein kinase C pathway. And the fourth one is advanced glycosylation end product pathway. Hyperglycemia leads to activation of all these pathways, which result in damage to microvasculature, leading to these microvascular complications. Earlier, it was believed that hyperglycemia directly activates all these pathways. But of course, 2 decades ago, it was proposed that the activation of all these 4 pathways by hyperglycemia is mediated through increased production of reactive oxygen species. Moving on to the risk factors. Of course, as I told earlier, hyperglycemia is the biggest risk factor. Longer the duration of diabetes, poorer the glycemic control, obviously the risk of microvascular complications will be significantly higher. In addition to hyperglycemia, it's a high blood pressure which also contributes to nephropathy and retinopathy. Similarly, dyslipidemia also contributes to nephropathy and retinopathy. Whereas age and height contribute significantly to the prevalence of neuropathy. Obesity contributes for retinopathy and neuropathy, whereas smoking contributes to nephropathy. Genetics, of course, though I have mentioned it here in neuropathy, where polymorphisms and aldoreductase predispose for neuropathy. Other genetic factors also predispose for retinopathy and nephropathy. And when to initiate screening for these microvascular complications in patients with type 1 diabetes mellitus? As suggested by ISPAD guidelines, any type 1 diabetes child or adolescent who is like already 11 years or more with a duration of at least 2 to 5 years should be screened for microvascular complications, whether it may be nephropathy, retinopathy, or neuropathy. So let me move on into the individual complication, where I'm going to discuss how to assess each microvascular complication and how to treat if the complications are detected. The first one is diabetic retinopathy. If you look at the classification of diabetic retinopathy, it is divided as non-proliferative diabetic retinopathy, which is again divided into mild, moderate, and severe, proliferative diabetic retinopathy, and diabetic macular edema. Mild non-proliferative diabetic retinopathy is defined by presence of at least one microaneurysm. As you can see, this cartoon is also enlarged to make it more clearly visible. At least one is present that's sufficient enough to make a diagnosis of mild non-proliferative diabetic retinopathy. Then what is moderate non-proliferative diabetic retinopathy? When the findings are beyond microaneurysms, which typically include dot and blot hemorrhages, hard exudates, the cotton wool spots, that is soft exudates, but they don't qualify for the definition of severe NPDR. So that is actually labeled as moderate NPDR. Then what is severe NPDR? The severe NPDR is typically described with 4:2:1 rule. What is this rule? So if the intraretinal hemorrhages of more than 20 are present in each of the 4 quadrants, or venous beading are present in 2 quadrants, or intraretinal microvascular abnormality is present at least in 1 quadrant, that qualifies for the definition of severe non-proliferative diabetic retinopathy. And of course, to classify under this group, there should be no features of proliferative diabetic retinopathy. Let's see what is proliferative diabetic retinopathy. Proliferative diabetic retinopathy is defined as features of severe NPDR along with evidence of neovascularization either at the disc or at the other places, what we call it as a neovascularization elsewhere. And there could also be vitreous or periretinal hemorrhage, the presence of which also qualify the retinopathy to include under proliferative diabetic retinopathy. Another important retinal manifestation, which we should be aware in diabetic patients because it's also associated with vision loss, as macular edema. So macular edema is classified as mild, moderate, and severe. In the mild macular edema, as you can see in the cartoon C, there is some hard exudates which are distant, bit distant from the center of the macula. Whereas in the moderate macular edema, the retinal thickening or the hard exudates are approaching the center, but not involving the center, as you can see in the cartoon D. What is the severe macular edema? The retinal thickening or the hard exudates involve the center of the macula here, as you can see in the cartoon F. Right. So once we understood what are the grades of retinopathy we can see in diabetic retinopathy, then how do we diagnose them? And typically, a decade ago, all patients with type 1 diabetes mellitus were referred to an ophthalmologist for evaluation of diabetic retinopathy. But however, with increasing availability of the handheld fundoscopes, it has become routine that in most of the clinics, the fundus examination is done using an handheld fundoscopy. Handheld fundoscopy pictures are often interpreted by the diabetologists themselves, or they seek the help of an artificial intelligence. So artificial intelligence actually requires an automated image analysis, which requires two 45-degree digital images from each eye, one centered on the macula and one centered on the optic nerve. Artificial intelligence provides a quick diagnosis within 20 seconds. It not only tells about the presence or absence of DR, but also tells about the grade of diabetic retinopathy. In fact, it has a good specificity and sensitivity to diagnose diabetic retinopathy. Another important tool in the evaluation of diabetic retinopathy is actually optical coherence tomography, basically meant to identify diabetic macular edema, where it is the most sensitive test. It requires cross-sectional images of the macula and allows objective evaluation of macular thickness, and also helps to determine the severity of diabetic macular edema. But of course, it's a costly and has poor correlation with visual acuity. So once we have treating a type 1 diabetes patient, if the patient has a does not have a diabetic retinopathy, the repeat screening can happen anywhere between 1 to 2 years later. But if you're dealing with a patient who has a mild NPDR, the follow-up should be at least once in a year, whereas for moderate NPDR patients, the follow-up should be at least once in 6 months, whereas for severe NPDR patients, the follow-up should be once in at least 3 months, whereas for PDR patients, the follow-up should be at least once in a month. For diabetic macular edema, if it's a severe one where the center is involved, follow-up should be at least once in a month, whereas where its center is not involved, the follow-up should be at least once in 3 months. But remember, any patient who has diabetic retinopathy, which is more than moderate NPDR, or equal to or more than moderate NPDR, should be referred to an ophthalmologist so that they would be closely followed up and the intervention can be given as soon as there is an indication. Then what are the recommendations for treatment in patients with diabetic retinopathy? They include the photocoagulation, that's a laser therapy, and the VEGF inhibitors. Both are equally effective. Usually the high PDR and severe NPDR and CSME are the ones which usually predispose for vision loss. And in patients with PDR and severe NPDR, the pan-retinal photocoagulation is used, as you can see the cartoon in the upper panel. Whereas in patients with clinically significant macular edema, grid laser therapy, as we can see in the lower panel, or focal laser therapy are used. In both the scenarios, you can use the anti-VEGF agents, which are equally effective. Let's move on to neuropathy. Neuropathy is a common complication of type 1 diabetes mellitus. Again, the most common among them is the distal symmetric polyneuropathy, which predisposes for larger morbidities. If we want to look at the definition of diabetic polyneuropathy, it's defined as the presence of symptoms and or signs of peripheral nerve dysfunction in people with diabetes after the exclusion of other causes. When we see about exclusion of other causes, there will be an exhaustive list given by many guidelines, but that may not be possible in the clinical setting to exclude all of these by doing an array of investigation. But what we do clinically, practically in our clinical settings, is to rule out hypothyroidism and vitamin B12 deficiency, which are the two common causes, easily accessible causes, and easily treatable causes. Of course, it does not mean that we should not look for other causes of neuropathy. Probably we need to suspect and evaluate for other causes of neuropathy only when there are atypical features. Then what are those atypical features which make us to suspect non-diabetic neuropathy? They include the predominant proximal involvement or predominant motor involvement, asymmetric involvement, or shorter duration of diabetes. So among these non-diabetic neuropathies, the most common one is the immune-mediated neuropathies, again, which should be evaluated because of the available treatment options, which can improve the outcome. Another point I would like to mention here is that if you have a patient with suspected type 1 diabetes where the diagnosis is not proven by the antibodies, and this patient develops early bladder dysfunction, think of Didmore syndrome, as it's very common in patients with Didmore to have early autonomic neuropathy and early bladder dysfunction. So the classification of diabetic neuropathy is basically divided into diffuse neuropathy, mononeuropathy, and radiculopathy. The diffuse neuropathy could be distal sensory peripheral neuropathy, which may affect small fiber or large fiber or both, or it could be autonomic, where it can affect each and every organ affected by the autonomic, supplied by the autonomic nervous system. The cardiovascular affection leads to postural hypotension. It can be seen on ECG as loss of heart rate variability. And it could be gastrointestinal, where this could be alternating diarrhea and constipation, or gastroparesis. It could be urogenital, where there could be a bladder dysfunction and impotence. It could be pseudomotor dysfunction. In fact, pseudomotor dysfunction behaves differently in the upper and lower half of the body. In the lower half of the body, it would reduce the sweating, leading to development of cracks, which may later get converted into diabetic ulcers. Whereas in the upper part of the body, it produces excessive sweating, especially involving the face and the upper chest, typically during intake of some hot or spicy meals. Hypoglycemic unawareness is another important manifestation of autonomic nervous system, which predisposes for development of severe hypoglycemias, and it's not only causes significant morbidity, also increases mortality. If you look at the mononeuropathies in diabetes patients, typically they are isolated cranial, involving third, fourth, or sixth because of microvasculature abnormality, more common in type 2 than type 1. Mononeuritis multiplex is another type where we need to think of non-diabetic neuropathies and rule them out. Another set of conditions where we need to rule out non-diabetic neuropathies are actually radiculopathies, including lumbosacral, proximal motor amyotrophy, where CADP could be a possibility and needs to be excluded. Pressure palsies can occur in type 1 diabetic patients. Another set of neuropathies which are unique to diabetic patients are the acute painful small fiber neuropathies, which may be associated with either hyperglycemia or treatment, which typically happens in patients who had long-standing poor glycemic control, in whom the hemoglobin A1C is reduced drastically with insulin therapy. If we look at the clinical features of diabetic neuropathy, they can be divided into small fiber affection and large fiber affection. The small fibers are typically the C fibers, and when they're affected, they lead to increased pain sensation, that is hyperalgesia. The pain is typically lancinating, stabbing, burning, or electric shock-like. They may have allodynia, that means even without any stimulation, they perceive pain. Decreased sweating will be there because of autonomic dysfunction, which leads to dryness and also maybe cracks. In the late stage, there will be hypoalgesia. But this is probably we need to be careful about. The patients often feel that the reduction of pain as an improvement in neuropathy, but it's not so. In fact, there is a deterioration, and that's the time when we need to be more careful because the risk of ulceration increases significantly once there is hypoalgesia. Of course, the manifestations of autonomic dysfunction, which I enumerated in my previous slide, could also be manifestations of small fiber involvement. The large fiber involvement, which typically affects the A delta fibers, is characterized by deep-seated dull aching pain, numbness, pins and needles, tingling. Often it results in frequent falls. In fact, large fiber neuropathy is kind of a less symptoms but more signs, whereas small fiber neuropathy is more symptoms but less signs. So then what are the signs of these neuropathies? In a small fiber neuropathy, there is a reduced pinprick and temperature sensation, along with features of autonomic dysfunction, such as postural drop in blood pressure. Whereas in large fiber neuropathy, there is decreased touch perception, vibration perception, and position sense. In addition, there is also loss of deep tendon reflexes, wasting and weakness of muscles, and also sensing. So, how do we assess the neuropathy at bedside? Of course, there are several tests which have been used in the diagnosis of neuropathy. But all what matters is that how do we comprehensively diagnose neuropathy in a short duration in our clinical setting? And the ADA recommends a set of investigation or set of tests to ensure the comprehensive diagnosis of neuropathy in clinical setting. They include testing for small fibers neuropathy, that is pinprick and temperature. Both would be reduced in patients with small fiber neuropathy. Whereas testing for the large fiber dysfunction include vibration perception, which can be done either by using a 128 Hertz tuning fork or by using a vibration perception threshold testing using a biothiometer. In fact, vibration perception threshold also grades the degree of vibration loss. The third important test is proprioception, which assesses the joint position sense, whereas the most important one is actually testing for touch pressure sensation by 10 gram monofilament. In fact, this is the one which tests for the protective sensation, and loss of this protective sensation, which is tested with a 10 gram monofilament, is one of the strong predictor of ulceration in the field. Of course, as we're all familiar with, ankle reflex could also be one sign of large fiber dysfunction, which can be easily elicited in the clinical setting. So how do we manage neuropathy? Basically, as we know, for any microvascular complication, providing good glycemic control is important. Though it does not reverse the complication, at least delay the further progression, it's very important. Another important aspect in the management of neuropathy is the painful neuropathy. In adults, we typically use pregabalin, duloxetine, and tapentadol ER, all of which are actually approved by the FDA. Other common agents which are not approved by FDA but we still commonly use are gabapentin, amitriptyline, and rarely tramadol. But in children, for example, if an adolescent develops painful neuropathy, so choosing a pain modifier would be a bit difficult. But however, with the experience of using pregabalin and gabapentin for seizure disorder and also for fibromyalgia in adolescents, it would be more comfortable to use the pregabalin and gabapentin for painful neuropathy in these patients. So we typically use or start from 75 microgram, so 75 milligram of pregabalin in adults. There are also preparations available in 25 mg, which can be used to initiate treatment in adolescents. The second important thing in the management of neuropathy is the foot care, because these neuropathic feet are at risk for ulcerations and cellulitis, and which may require amputation. And hence, all type 1 diabetic patients with neuropathy should be educated about foot care, which I'm going to take up in next slide. And whoever has foot deformity on examination should be prescribed a therapeutic foot care. So what are the points we should educate our patients for foot care? We should advise them to wash their feet regularly with normal temperature water or warm water. Warn them that when they're using water to wash their feet, they're not using too hot water, otherwise it may result in scald and they may not realize that the pain of burn, so it may result into ulcerations as well. Once they wash their feet, they need to dry it out well, including in between the toes, and then they should apply some moisturizing cream. That moisturizing cream should not be applied in between toes, and they should inspect their feet every day, because once the soles lose the sensation, the preserved vision should act as the skin of the sole to look for any injuries which might have happened. Major problem is when they don't have sensations, when they get injury, they don't realize that. And by the time they realize that, it's already be cellulitis or septicemia. Another thing is to train them to trim their nails straight so that it does not result in ingrowing toenails, or result in any injury. Also, educate them to use appropriate socks and footwear. Ask them never to walk barefoot, and also to examine their shoes every day before wearing them. Moving on to nephropathy. Nephropathy is clinically characterized as a triad of hypertension, proteinuria, and ultimately renal impairment. If we look at the stages of diabetic nephropathy, the first two stages often we miss. We don't even realize these stages. Even the screening protocols are trying to diagnose diabetic nephropathy in the third stage, that is the microalbuminuria. And once the microalbuminuria progresses to macroalbuminuria, the progression is much faster, finally resulting in renal impairment. How do we screen for diabetic nephropathy? That's typically by the spot urinary albumin to creatinine ratio using the first morning sample. A value of more than 30 milligram per gram of creatinine in males and more than 42 milligram per gram of creatinine in females is considered as abnormal. But don't hurry up to make a diagnosis of diabetic nephropathy by one value of microalbuminuria, because there are several confounding factors which can result in false microalbuminuria, which include strenuous exercise, infections, especially in the urine, few other kidney diseases, marked hyperglycemia, fever, and menstrual bleeding. And that's the reason it is insisted that before making a diagnosis of diabetic nephropathy, microalbuminuria should be confirmed in a second sample, which is placed 3 to 6 months. Another important factor in screening of type 1 diabetic patients for nephropathy is also to consider the non-proteinuric diabetic kidney disease. Though it is less common than seen in type 2 diabetes patients, but it is still observed in 20% of type 1 diabetes patients. Then how do we screen for it? Typically, it is the EGFR, which has to be calculated using the serum creatinine and the appropriate formulas for estimation of EFR. So how do we treat diabetic nephropathy? In addition to the glycemic control, what is more important, especially for nephropathy, is blood pressure control. If a child or adolescent has a BP of more than 98th percentile for age, gender, and height, definitely start the patient on lifestyle intervention, which includes exercise, reducing screen time, and diet. But if the blood pressure is still more than 90th percentile despite lifestyle intervention, start the patient on a BP lowering medication. If it's microalbuminuria is already present, and it should be an ACE inhibitor or an ARB. But if we encounter a child or adolescent with type 1 diabetes who has a blood pressure of more than 90th percentile at the diagnosis, then in addition to the lifestyle intervention, simultaneously antihypertensive drugs should also be started, preferably ACE inhibitor or ARB in patients with microalbuminuria. Next important thing is lipid control. Although we all know that nephrotic syndrome leads to dyslipidemia, so when probably dealing directly with diabetic patients, we may forget that fact. So we need to remember that proteinuria further increases dyslipidemia in patients with type 1 diabetes mellitus. Whenever the LDL cholesterol is more than 100 milligram per deciliter, we need to start them on dietary and lifestyle intervention. If it works, well and good, but it doesn't work, or the initial LDL cholesterol itself is more than 130 milligram per deciliter, the patients can be started on statins. In fact, we have a good number of statins which have been approved for the adolescent age group, which can be used in patients who qualify for these criteria. If we look at the nutrition, so we need to cut down the proteins once the proteinuria sets in for patients who are not on dialysis. Typically recommended to keep protein at around 0.8 gram per kg per day. But what I caution here is that the protein intake and most of our type 1 diabetic patients already may not be reaching this goal also. And if we ask them to further cut down the protein intake, it would be a disaster. So hence, it would be essential first to assess the amount of protein consumed by a child and then to advise restriction only if it is in excess. On the contrary, in dialysis patients, higher dietary protein supplementation is required. We need to restrict sodium in these patients with nephropathy. Typically in adults, we restrict to less than 2.3 gram per day, which corresponds approximately to 5.5 5 to 6 grams of common salt. We also need to reduce potassium in the diet, especially if the eGFR is low. A special caution in diabetic patients is that both type 1 and as well as type 2 diabetic patients suffer from hyporeninemic hypoaldosteronism, leading to type 4 RTA. This makes them more prone for hyperkalemia at a lower level of creatinine. So hence, they should be closely monitored for hyperkalemia. When to refer a type 1D patient to a nephrologist? So whenever there's a significantly reduced renal function, that is eGFR less than 30, obviously we need to refer because they have to prepare for dialysis or a renal replacement therapy. Another important caution I would like to tell you here is that compared to non-CKD, non-DKD chronic kidney disease patients, those who are having diabetic kidney diseases are more likely to have volume overload at a lower creatinine level. So that's why we need to be more careful and probably have to consider a bit early to refer to the nephrologist. In addition, those patients who have refractory hypertension, refractory anemia, or where you're suspecting a non-diabetic nephropathy in a diabetic patient should be referred to a nephrologist. So then when do we suspect non-diabetic nephropathy? Whenever a patient comes with significant hematuria, have active urinary sediments, or there is a rapid reduction in eGFR, or there is a rapid progression or onset of proteinuria, should be referred to a nephrologist. And of course, although it's not mandatory that all diabetic nephropathy patients should have diabetic retinopathy, but absence of diabetic retinopathy should raise suspicion for presence of a non-diabetic kidney disease in a diabetic patient. To summarize, as per the ISPAD guidelines, the screening for microvascular complications should be initiated in all patients by 11 years of age who have at least a 2 to 5 years of diabetes duration. So it should typically include urinary albumin creatinine ratio for nephropathy and also serum creatinine with estimated eGFR at least once in a year. And retinopathy screening should include fundus photography or a mydriatic ophthalmoscopy. Neuropathy screening should include history, physical examination, and a comprehensive test what I listed previously. And the screening for microvascular disease, though it's not included in today's discussion, but they also significantly contribute to the progression of some microvascular complications, especially nephropathy. So hence, it's very important also that they're monitored for dyslipidemia and hypertension. If you look at the treatment and want to summarize it, look at the general measures, which are very essential. That's intense glycemic control, blood pressure control, management of dyslipidemia, and cessation of smoking. Whereas the microvascular complications and the specific treatments, if you want to summarize, they include laser treatment and anti-VEGF inhibitors for patients with severe NPDR, PDR, and clinically significant macular edema, ACE inhibitors or ARBs to prevent and treat proteinuria, and foot care to prevent ulcers and neuropathic pain management. Thank you so much.